with a 65-year-old woman. This is actually not the actual woman, okay, and referred because of a question of treating based on FRAX scores, okay, and so she had a follow-up DEXA. We'll get to DEXA scores in a second. Basically, she's healthy. She exercises mostly with activity at work and has not been experiencing falls, except 8 years ago she fractured her right wrist with a very hard fall on ice, and she felt like on her way down she felt like she was going to fracture her wrist, so it was that hard. And that was 8 years ago. No glucocorticoid therapy, no alcohol, tobacco abuse, and her mother had a hip fracture at age 89. Okay, so these are some of the ones that some of the data that you'll put into the FRAX calculations. How many of you are using FRAX calculations? Okay, okay. Okay, and so these are her bone densities. The most recent ones, which were earlier this year, give T-scores of -1.8, -2, -1.8 at the lumbar spine, -2 at the femoral neck, -1.8 at the total hip, okay? And comparison between 2012 and this year, lumbar spine went from 977 to 963, which is not a significant difference. You can get that much difference just getting on the machine, off the machine, back on the machine. Femoral neck, 760, 755, again, pretty identical numbers. And total hips, 0.777 to 0.781, pretty identical numbers. So they look pretty much the same over the last 3 years. Now, if you take her information and plug it into the FRAX scores, she has a 10-year risk of major osteoporotic fracture of 30% and a hip fracture of 2.8%. And so FRAX started off as just a way to kind of get an idea of what the fracture risk is in advising patients. And then it was refined. Version 2 of FRAX then gave you guidelines about whether to treat or not to treat based on these scores. And what are you using for your threshold for treating if you use this for major osteoporotic fracture? 20%. And for the hip? 3%, okay. And so here's this patient. She did have a fracture of her wrist that I described, and her mother had that hip fracture I described. Would you treat this patient with anti-resorptive drugs to reduce your risk of fracture? Okay. So according to this, you would. Okay. Now, if I didn't give you this, and before they started doing FRAX scores, would you treat this patient? You know, moderate osteopenia, a fracture with a hard fall 8 years ago. A mother had a hip fracture at age 89, and her bone density is doing nothing. It's just staying stable. It's in an osteopenic range. That doesn't fall into my threshold for treating. The intermittent physician who sent her to me felt like this was telling her to treat, but she didn't want to treat, and wanted to get my opinion on it. So this kind of brings up, this is one of my 2 cases about FRAX scores and about the limitations that are actually published by the FRAX people, and kind of how I use it and how I don't use it, get insights for how you're using it for me. Okay, you're used to this form that you fill out, and with previous fracture, parent has a fractured hip, smoking, glucocorticoids, rheumatoid arthritis, secondary osteoporosis being something else is causing it besides just aging, alcohol abuse, and then filling in the femoral neck bone density with whichever instrument you're using. Okay. So this was developed, so a little background on this that goes into how I use it. Developed in 2008, okay? So that's less than 10 years ago. So there are not FRAX data using the actual FRAX measurements with prospective data to see what does happen in the next 10 years. So the data that you do have is based on other population studies with epidemiologic studies taking a look at risks for fractures and about what fracture rate they're seeing over 10 years in these various populations, okay? Very similar to how they got the WHO predicted fracture risk with T-scores in the first place, based on big population studies. Okay, actually, this is a little bit, if you look at summaries, they'll say this is to be used at women and men age 50. The WHO task force actually says greater than age 40 without previous therapy or without current therapy, okay? Now, some of the caveats that are brought up by the group itself is, one, previous osteoporotic fracture. What counts as an osteoporotic fracture? Did that falling on the ice count? Okay. Certainly, if you fall in the kitchen and break your hip, that's an osteoporotic fracture. But what's the threshold for putting it into these calculations? Hip fracture in the parent, what counts? There's a hip fracture at age 75 count? Absolutely. How much weight does that put in for a hip fracture at 89? You know, we don't really know. But certainly, I would pay more attention to a hip fracture in the 70s than in the 80s. If the spine bone density is clearly lower than the hip, then it's really not geared to use this, although over the past year or two, you know, they put fudge factors in for this too, to have further calculations about predicting fracture risk. And it doesn't take into account the rate of change. So if the bone density is going like this, I'm going to view that differently than if it's going like this. And the long-term risk for many of my patients is difficult to translate. So what does a 3.5% increase risk chance of fracture over 10 years of the hip mean over 10 years? And if I divide that by 10, what does that mean? The other thing is that, but I don't think it's a particular limitation, that the number of previous fractures is not taken into account. So if you have somebody with 3 fragility fractures, you're going to be much more likely to treat than somebody who fell and fractured the wrist on ice, just, you know, without this, okay? So I think there's certain limitations. Do you know how they got to those thresholds of 3% and 10%? Okay. So one, when they took a look at all this data, they made thresholds for being cost effective. And these were based on a lot of assumptions themselves. For instance, it was assuming a cost of $600 per year for drugs, okay, which is way less, generic alendronate's way less than that. Some of the drugs like Reclass, Prolia are way more than that. So $600 a year, and assuming a kind of a threshold, spending $60,000 per quality of life adjusted year. So for every year of quality of life that you gain, if you're spending $60,000, that's cost effective. That's just kind of a figure that's put out there in medicine. Now, and these thresholds vary according to age and a little bit to gender, so that the 65-year-old woman, if you use these parameters and you're using something that's $600 a year, her threshold ends up being 4%, okay, not 3%. So there's a lot of little caveats and adjustments that all are in back of these FRAX calculations. Though what got me thinking about really was that last year's Endocrine Society meeting, a featured Meet the Professor person presented a patient very much like I just showed you, and did all these calculations, didn't talk much about the patient, but talked a lot about numbers, and ended up treating a patient just like this with these scores with Forteo, started her on Forteo, and had a whole adjustment, and that's $6,000 per year, and then that doesn't get anywhere close to this cost effectiveness. So, so I think there's a lot of ways for these calculations to get 2, 3 steps away from the patient. So anytime that you're doing all these calculations that are based on assumptions, it always makes me worried about what my final decision for the patient is. Okay? But I do FRAX calculations. Any questions so far about this? Okay. And again, these are all the factors considered that we just went over on that form for FRAX. Okay. Okay, so I use these as guidelines, just like the T-score, that it gives me kind of one more figure that tells me roughly what the patient's fracture risk is, but I still have to apply it. You know, if I see the patient's bone density staying steady, I'm going to adjust how I apply these FRAX scores. If I think that that osteoporotic fracture really wasn't an osteoporotic fracture and it was 8 years ago when she didn't have osteoporosis or when her T-scores were higher, I'm not going to pay that much attention to it. So I think I still base this a lot on my clinical interpretation of how I apply those numbers. So personally, I would come down to this patient with moderate osteopenia, not osteoporosis, a fracture 8 years ago that could have been a traumatic fracture. Even though she's got this figure of 30% risk of non-osteoporotic fracture for the next 10 years, I'm not sure how much I believe that for all the calculations that went through. Does that match my clinical presentation? And for me, and also for the physician who referred her, we felt comfortable in saying it's okay to just watch, okay? But that's kind of my background on FRAX right now. I just use it to give me a flavor. I actually don't use those numbers as rules to make the final decision regarding therapy or no therapy. Yeah. Okay, so now I'm going to, we'll do one more FRAX. And this patient, you're going to tell me, well, I wouldn't do a FRAX score in that patient anyway, but so I'm using it for illustration. So this will be a perimenopausal woman, okay, who's considering osteoporosis therapy. She has questions about a particular brand, but we won't go into that yet, okay? And 50-year-old, newly diagnosed with osteoporosis, and then in the history, you're going to be going through the same things that I just showed you, that, you know, the history that you get to fill in the FRAX forms are really appropriate history for considering your patient. So her history is that she had 2 toe fractures years ago when she stubbed her toes hard against a curb, okay? She has a mother with a hip fracture at age 72, no falls, no glucocorticoid therapy, no alcohol, tobacco abuse. Menopause was 3 years ago, and because she had the onset of vasomotor symptoms, her physician prescribed Vivel at a 0.0375 dose, okay? So she's being referred because she also had another DEXA, and you know, and she had a DEXA originally because she was thought to possibly be at increased risk of osteoporosis at the time of menopause because of her mother's hip fracture at age 72. Okay, so in 2015, her T-scores of the lumbar spine, just in the osteoporotic range, osteopenia at the femoral neck and total hip, and the change, which is why she was referred, was 0.957 to 0.860, or a 10.1% change over the those 3 years into the osteoporotic range. So she's going down more rapidly. Femoral neck, 0.842 to 0.797. So how do you tell if that's a significant change? So Deb, what's your threshold here for a change at the total hip?
Let's change, so we just got it in. I think it was 0.4.
0.043? Okay. So typically a change of that should be 0.04, okay? At the femoral neck is considered significant, 0.03 about then of the 0.03 at the total hip, and 0.02 at the spine. So in that ballpark is considering, yeah. So there should be an extra O in all those. Okay, and those also are all based on if you do your studies the same way we do ours, you have a bunch of people that get the bone density measured, go walk up and down the hall and get it measured again. Same tech, same day. The tech knows that this is the quality that are being generated. So it may not be the same if they're coming back 3 years later with a busy tech on a different day. But still, it's the best we had to go by, so we go by the same thing you do. Okay, so these are all what we would consider real changes as far as downward, particularly at the spine. Okay, so knowing what you know about the history of this patient, is there any? What would you do at this point? Okay, and this is where I'm going to insert your questions. Okay, so is there anything that concerns you about this patient more than just your a patient coming in with a decreased bone loss at 2 intervals? Okay, so you want to know some things about this patient. And why are you asking about labs in this patient? Right, because her bone density is decreasing despite being on estrogen, okay? She was prescribed estrogen, which should be as protective as any of the other anti-resorptives, and she's had a fairly good decrease at the spine over the last 3 years. So, the referral to me was asking, are there secondary causes of her osteoporosis, and what should we do about this patient? So what I do for secondary causes is I do, the first thing I measure, exactly what Tim said, is a vitamin D, 25-hydroxy vitamin D. I went into vitamin D last year, so Tim made me promise not to talk about it again this year. And then I will also get a parathyroid hormone and calcium. Because taking a look for primary or secondary hyperparathyroidism will cover several causes of potential increased bone loss. Primary hyperparathyroidism, renal calcium leak, malabsorption. There will be supportive evidence for vitamin D deficiency. And then if the PTH and the calcium come back abnormal, I'll look further into that. She's really healthy. So things like a serum protein electrophoresis for taking a look at multiple myeloma because you're getting a bone decrease at the spine are going to be very low yield tests in somebody who's basically healthy. So I basically limit it in somebody who's really healthy without any history of something else going on to the PTH, calcium, and vitamin D, and then go from there.
What about thyroid? You thought that if there's asymptomatic?
Yeah, if she's asymptomatic, that she's going to have, if she has hyperthyroidism, it's going to be subclinical hyperthyroidism, which really means subclinical, including the effect on bone. The exception being, we know over time, mild hyperthyroidism can slightly increase the rate of bone loss in menopausal women. You know, so when she gets older, I'll probably look for that, but she's totally asymptomatic. The other important history is what she got on glucocorticoid use during this time, because that gives selective bone loss at the spine, and she wasn't. So by my history, and then I'll do these couple labs, then I'll be considering what's going on. So what else, but what haven't I included in my history that you might want to include in your history, which is something that Ann wanted me to talk about? We'll get, you'll tell me in a second. Okay, so she ended up having normal labs. So now I know the normal labs. I'm still surprised by one thing, right? Yes?
So the fact that her hip, both her T-score for her hip is fine, and Spratt.
Yeah, so you're going to say one, it's her spine that's lower than the hips, so you can't use FRAX anyway. And the other thing is you already have a -2.7 T-score at the spine, so So you're already into the WHO and NLF guidelines for considering treatment because she already has one bone density in the osteoporotic range. So you're absolutely right. You wouldn't even calculate FRAX scores, but I did it for fun to present to you. Okay, so yeah, you're absolutely right. You're not going to make you're going to base your treatment recommendations on clinical circumstance in the -2.7, not on the FRAX score. But here's somebody that you know that you're going to be considering treatment on. Bone density is going down relatively rapidly, and it's into the osteoporotic range. And look at the FRAX scores on that. And the FRAX scores are way below your thresholds for treatment. So again, these are manufactured, calculated figures that can be very separated from the clinical circumstance. So I use them only as guidelines to give me a flavor, and I pay less attention to them if they don't match my clinical situation for FRAX. Yes?
And with this one, do you kind of dial down and look at the actual scores for each individual? Like if looking at our lumbar spine, do you let them know that what for L1, L2, L3, numbers are obviously the severity? Because her average is -2.7, but she may have some vertebrae that are like -3.2 or higher usually.
Yeah, and Deb has already done that for me before they come over, right? She's looked at them individually, but I look at them individually too. And then because one, she's 50 years old, so she's probably not going to have much artifact of the vertebrae. So if I were to say she's -2.7, if she had one vertebrae that was 0, and then the other ones were -3.4, -3.7, and the 0 probably has some artifact in it. So, but Deb would have already thrown that one out in the analysis. But then when I see this decrease in bone density that I'm going to be paying a lot of attention to as far as treatment, I look at what is the change in each vertebrae as it goes along, and am I seeing that just in one? And then I'm going to ask Deb, is this a technical thing, or am I really seeing it consistently in all four, so I believe it's real? So I do look at each one. Yeah. Okay. So and Deb had looked at each one in here, and it looked like a real decrease at the spine. There were no technical issues at all. So there's still something about this patient that's unusual. Okay? She's on estrogen, and her bone density is decreasing. Well, estrogen doesn't protect everybody. You know, the bisphosphonates would protect 90% of people. But what's the first thing you're going to ask her about her estrogen? Is she using it? Right. And she's scared to death because of breast cancer, heart attacks, all sorts of things. So she will put, every time her hot flushes and nights get intolerable, she'll put a patch on for a couple days and take it off. And that happens every 3 or 4 weeks. Okay? So she's been using estrogen, but not at an effective dose to decrease bone density, to protect bone density. So, and the other thing is that she's just in her first 3 years of menopause. And for 3 to 5 years, you get this increase rate of bone loss, and then it becomes more shallow again. And so I'm less likely to think that with estrogen deficiency, she's not being treated with estrogen. I'm more likely to think that that 10% decrease is just part of normal menopause versus something else, okay? Would you treat her? Yeah, what would you treat her with? You could treat her with a bisphosphonate. Will that help her hot flushes? Okay. So I'm coming from reproductive endocrinology, okay, okay, and so I'm thinking, hey, there's something I can do here to make this patient feel better, you know, and so these are all the things you have to choose from, but don't forget that estrogen's in there as a choice that works just as well as all these in patients where you're already going to be treating them for hot flushes. What's her risk of being on estrogen? Why was she scared? Well, she's on estrogen actually with progesterone. For the breast cancer, this is just quickly, for the first 4 years of treatment, there is no increased risk of breast cancer by multiple studies, including the Women's Health Initiative. And then you go from a 10% lifetime risk to a 12% lifetime risk. if you're extending your treatment beyond the 4 years. You go from, in a healthy 50-year-old like this, your risk of DVT goes from 1 in 10,000 to 2 in 10,000. Risk of stroke goes from 1 in 80,000 to 2 in 80,000. And I go over these risks and say, okay, you're balancing benefit versus risk. It's totally your choice, as long as you understand what the benefits and risks are. It's quality of life versus these risks. So if there's, no hot flushes or night sweats, then it's probably not worth these little risks. So, and she also felt like using the estrogen was cosmetic because it was treating hot flushes, which was an optional thing. So, so we kind of went over that she was okay to be using it for hot flushes. That's what you use it for. Okay. I'm going to show you just a couple things here. These are costs per year, and the hormone replacement therapy ends up being a little bit over $100, so it's more like the generic alendronate. And these are through Walmart's costs for about a year ago, and the Forteo, as I said, ends up being about $6,000 in here, just compared to cost. Okay. How well does the estrogen work? Studied a long time ago in menopausal women. The calcium vitamin D group, okay, this is the spine. This is comparing it to alendronate. So the alendronate goes up here, up about 6% as you'd expect. The diamonds are the estrogen right along with the alendronate, and this is combined, which is a little bit better, but it wasn't statistically better, and certainly doesn't look like it gives a clinical advantage. And you see the same thing at the hip. Okay, so estrogen, as far as bone density, works just as well as the other anti-resorptive therapies. Now, with the Women's Health Initiative, we also know that it has the same fracture prevention properties. If you stop it, you start going down about as if from the point where you started it. So that if you're in the first year of menopause, you take it for 5 years. Stop it, you'll have right away that rapid menopausal loss. Prolia is the same way. When you stop it, you take up wherever you're going to be. The bisphosphonates give you about a year grace period of minimizing bone density for about a year after you stop it. Yeah. Okay. Now, this is your introduction. And spend as much time as you want, but spend more than 2 minutes because it'll take you more than 2 minutes.
So I wasn't going to go over it page by page, but as you kind of get from Dr. Spratt's talk, bone density, and determining what you're going to do with patients and when you're going to test them and when you're going to treat them is such a patient-dependent thing. There's a lot of gray areas. There's not one society that says this is the exact way to do it. So what I did is I looked at a lot of different sources. I listed at the end here. Like the National Osteoporosis Foundation, International Society for Clinical Anthropometry, up to date. There's a lot of this is based on osteoporosis and the treatment guidelines that I found that did a good job and had a lot of other articles that they cited for that. US Task Force and the CME Wisely. And so what I did is look kind of where there was some agreement and what made sense and what would most likely not have us convince people we should be tested. And then, also at the end, there's a little caveat that says, just like a practice score, these are just guidelines. So you have to kind of take into account your particular patient, and it might not fit neatly in it. So the first case is which factors for low bone density, and you can see there's a lot of them, which kind of brings to mind when you're looking at a patient. And I'll go over, initial DEXA testing. You might read a lot now, oh, don't bother until they're 65. So if you just think about that, you're going to miss a lot of people that didn't have bone density testing. And that goes to that first graph. Your product fractures and when we compare to other diseases is a big problem. And we're tackling the registries for people with heart disease, diabetes, and all that stuff all the time. Product fractures are pretty up there. So always trying to think about those risk factors for low bone density to make you think about, well, should I be getting this bone density test before the person is 65 years old? And then also, once you get the test, thinking about it's a new thing since they had their first one. You might not originally have ordered a bone density test that early, but they have a new medical problem, maybe you can get it earlier. So initial testing, as I said, in general, women over 65 should think about doing it. General screening over 65, and they don't have necessarily any of the risk factors. Women less than 65 or men over 50 who are increased because of lifestyle medications, things that are on that list. Any women or men who suffer a low impact fracture, we kind of talked about, fall in the kitchen or fall in the ice, and kind of have to go over the cell on that. But obviously, if they're in a big auto accident, that's not a fragility fracture. Some societies, they consider doing a general screening bone density test on any men over age 70. I don't really agree on that. And then we often will get x-rays on people, and then the radiologist says, look on an x-ray. It's not even the risk factors that you know of, but that's just kind of something that you check. So that's kind of initial, and then a lot of questions come of when are you going to do the next one, after this first one. And I think a way of looking at it kind of cleanly is just looking at the T-score, and they break that down in ranges of T-score over negative 1.5, from negative 1.5 to negative 1.9, from 2 to negative 2.4, and then if they're osteoporotic, they want treatment, or they're osteoporotic, they don't want treatment. And then there's other subspecial groupings, like people who are on steroids, on anti-estrogen or anti-androgen meds, and then people who are still high risk because of that big long list of risk factors. And you can see there's a range of we can use the bone density test, like the T-score negative 1.5 to negative 1.9. It says may repeat the DEXA in 3 to 5 years. So that goes back to have to look at your individual patient. You don't have to repeat it in 3 years. You might want to make it 5. It kind of depends on the risk factors, and it might also depend on I think Dr. Spratt is a couple in a row, and they look pretty good and stable, and you don't necessarily have to keep doing it every 3 years. You might stretch it out. So I see some latitude with that. The next table is follow-up of this test for patellar fracture, and that comes up a lot where they know they're osteopenic already, then they fall and they go to hip, or they fracture a wrist, and then should I check it again? So the general thought is after you heal the fracture and they're not on medication, to then figure out where they're at. And then also, if it's a low impact fragility fracture, think about that list of secondary causes and go back to checking labs for calcium PTs and things like that. If they're already on bone osteoporosis medication, you don't have to repeat it right away. So you just started them on it 6 months ago and then it's fractured. Doesn't really make sense to check another bone density test because you have to have more tests. Your therapy not to really change the therapy. So you want to really get considered. And then going back to my third auto accident, I don't have to jump to do bone density test even if it has a couple of factors. But you can list all that too. So it's general guidelines, so the fact that you have to think about the individual patient and also think each year as something changes in this person's medical conditions that they're on, and should I be thinking about ordering or holding on?
Great, thanks. So I'm going to do 4 points, one a minute, except the last one I'm going to take 2 minutes, okay? First is compliance that Ann asked me to talk about, and non-compliance of the once a week, once a month pills is really, really common. So I always ask about that. I don't do any tests to figure out if they're complying. I trust their history. And if compliance is an issue, then I bring up the options of reclassed or Prolia, and that's my way to offer an option to help with compliance. You know. Okay. Point number 2 is what's the calcium and vitamin D controversy? Well, vitamin D controversy about giving big doses is gone. You know, almost nobody's giving these 50,000 units once a week loading doses when somebody has a vitamin D of 18 or 16. And so it's back to the 800 units, 1,000 units a day dosing, which the up-to-date section on this stuff, Cliff Rosen wrote, and it's really good, okay? But the controversy comes with, so this is the dosing, that there is a slight reduced risk of decreased rate of bone loss with these. The effect on fracture is unclear, so we don't know for sure that calcium and vitamin D benefits by decreasing fracture risk, okay? Then the big controversy is cardiovascular disease. The Women's Health Initiative noted no increased incidence of MI with calcium supplementation, but there were 2 meta-analyses who did report these figures on this, that in elderly patients getting calcium versus placebo, so these are meta-analyses, there was increased risk of MI, but the trials weren't designed to evaluate cardiovascular outcomes, and the outcomes weren't formally collected because of that, nor were they adjudicated. So these were like suggestive at the best. And other meta-analyses didn't confirm this. So it came down to, well, there's a slight evidence for maybe having increased incidence of MIs in elderly patients with cardiovascular disease, so that the recommendation was don't give calcium to supplementations in elderly patients who don't have osteoporosis, but it's still okay to give calcium to elderly patients with osteoporosis. And that's what the calcium controversy was that the Institute of Medicine put out. Any questions about that? So I don't give calcium to elderly patients without osteoporosis. Okay. Last thing is what I was spending 2 minutes on is the Prolia. Well, actually, the very last thing is, in the article they handed out is the best discussion that I've ever seen of the potential adverse effects. It's short, to the point, well-referenced, particularly the atypical femoral fractures. So I'm going to refer you to read that. It's really short, okay? That's longer than 2 minutes. Denosumab, or Prolia. The very last thing I'm going to say is, when would you use it? Well, we already talked about it's an option for improving compliance in patients that you're treating by the guidelines. And there's the other 2 situations are, I'm going to skip the mechanism of action, okay? So it goes up nicely over 3 years, but now we have 7-year data. This is the 5-year data, as opposed to the other antiresorptives that kind of plateau out after 2 to 3 years. This one keeps going up. Does this 6 and 7 years too. So there may be an advantage in your patients starting out with fairly marked osteoporosis, and you want to get them up closer to the normal range over a long period of time, to having a greater increase. See, that's up to 14% as opposed to the 7% I showed you. So maybe an advantage in a patient with a more severe osteoporosis, but we don't know that that reduces the fracture risk any more than the other antiresorptives. Okay, so maybe, okay? And then this was just a comparison with what I showed you before. The other thing is, I'm going to skip over this to show you the last point, which is if you are transitioning off of alendronate, and the same thing is true with vandronate, which is my next slide, and the patient still has osteoporosis, you know, maybe a T-score of -3.2, they've been on alendronate for a while, you'd like to get them up more, they're just doing nothing on the alendronate. This is switching them to denosumab, this is keeping them on alendronate, and it looks like you can get more of a, you can introduce some more increase in bone density. And I will recommend this in, say, a patient who has had a new fracture on alendronate and the bone density is still medium osteoporosis, it hasn't increased, maybe get some more increase in advantage. Now, I don't know for sure that that decreases fracture risk any more than staying on alendronate, but this would be the other situation that I would consider the denosumab. Okay. So let me stop there. There's still plenty of sandwiches in the back. Okay.
I have a question.
Yeah.
Just got from this lady here. So she has a T-score, I think, of -0.3. She's been on alendronate 5 years, and she has decreased.
Yeah.
So we stopped using alendronate. I think her last dose was 2013, and now she's decreased. So I was going to put her on Prolia, but what do I mean? What? So
Yeah.
she kind of maxed out 5 years on the alendronate.
Yeah. Yeah, that's exactly the situation I'm talking about. Yeah. Yeah, denosumab is just is the generic. Yeah.
But as like a second, so you kind of maxed out on your phosphonate. Now can I go to the almost like a second line?
Yeah, that's what I do. Yeah. I don't have fracture data as evidence for that, but yeah, if they're doing what you said, that's what I consider.
So just when I was reading the side effects, the long bone fractures and the osteonecrosis, is that, so the longer you're on these agents, the higher the risk of that. Is that additive with Prolia? So they've been on 5 years of bisphosphonates, and I know it goes up after 5 years. Yeah. So is it additive when I add the Prolia, or is it?
No. Okay, we don't know that. Okay. You'll see in here the atypical fractures of the femur are all based on case reports and case series, okay? And they're so rare that a definite connection has been difficult to establish. But in there, for the first time, they actually believe that there is a association between increased risk that increases over time, but the risk is way smaller than not treating and getting a fracture. Okay, so it's that benefit risk thing.
I mean,
yeah.
Not after 2 years.
No, yeah, and read that thing in there because the patient, that's what the patients are scared of right now. The osteonecrosis of the jaw, it looks like it's the same instance as somebody not taking the drug if they're not being treated for cancer, and that's not time dependent. That's, you know, if there is a risk, which it doesn't look like there is, it's the same after you start. Yeah. Thanks.
Thank you. The other thing too is that you can, we just went to the APC meeting and there were a couple of conferences where they are really pushing the topical estrogen. They're saying basically no, because I went to one, you went to one that says go for it. It's really just no increased risk.
Yeah.
Oh, no, the one I went to was topical. He was saying oral.
Oral rather than patch. Yeah, that the risk with oral is really not as bad as we've seen it have been.
Well, the risk is kind of what I was saying. But with they say there's no risk with the patch. But to find that risk of the oral, you had to have these huge studies. So none of those have been done on the patch. Yeah.
I just thought they were really pushing it.
Yeah. Are they connected? I was wondering if the guy that was using Forteo for somebody with osteopenia with no fractures was sponsored by that company.
Exactly.
Yeah. Because I thought, am I missing something? And I went to what Cliff's writing, and Cliff would not use that.
Yeah. Thank you.
Would you like to spec?
Yeah.